So here we go. Exam 3 review. I want you all to know I'm working on a Kahoots for the HESI review. Now, I don't know when I'm giving it because I'm having my daughter getting married in Mexico in 2 weeks. So I'm trying to get everything for RNPN, all your reviews in before that. So it might be a recording. I'll do something to help you all, okay? Yes, if you need to get up and do something, please go ahead. I understand it. If you need to eat, have something to eat. I know you guys are busy. You're as busy as I am. So, not a problem. So let's go ahead from the beginning. So these are chapters 25, 26, 27, 28, 29, 30, 31, 32. It is a lot of chapters, and it is in minimal weeks that we're doing these things. So getting that information to you is, what's important for me. So let's go ahead and start from the beginning. Let's go start with chapter 25. Now, I will tell you this exam is heavy, heavy, heavy respiratory cardiac. I will tell you that. Very heavy. So if you're going to focus some attention, respiratory cardiac. And that's just a heads up, and I tell all the students that. So, first of all, let's talk about ventilation. And what is it? It's just basically the process of breathing in and out. That's how we ventilate the air in and out. Bring the oxygen in and blow carbon dioxide out. Simple. Red blood cells. They're also known as erythrocytes. Okay, that's an important name. And what do erythrocytes do? Well, they carry nutrients, iron, and oxygen, and carries it around to the cells. And it also takes that CO2 back to the lungs and they can get rid of it. So erythrocytes are a very important component of the blood. That is a red blood cell. Now, there is always confusion. What is a good oxygen saturation for children? Some people at 92 are like, oh my God, we need to put oxygen on this person, this patient, this adult, this child. Well, we consider 90%. Now, in cardiac world, there are some that we don't want it that high, but let's just put general, all right? I'm not going to confuse you there. I'm just giving you that heads up that could be something different. Now, what are signs of respiratory distress? What would this child be showing you? Well, it depends on age. That's one of the things. But in general, what do we see? They're going to be tachypnic. They're breathing really fast. You're going to hear some sort of sounds in the lungs, whether it is water, as in rails, mucus, which is rhonchi, and wheezing, which is that constriction that you'll see with your asthma. You'll also see them pulling every muscle, the accessory muscles. You'll see between their clavicles will be pulling in, which doesn't normally happen. You're going to see them cyanotic because as respiratory distress continues, you're going to see oxygen saturations drop. So you'll see that. And when you see that, your lack of oxygen, you always get that irritability, restless, confused. You sort of, where am I type of experience. You're not getting oxygen to the brain. How can the brain think without oxygen? And then the other thing we hear is stridor. And stridor is all those tracheobronchial type of things. That is your croup. That is your epiglottitis. So wheezing is your asthma, and the stridor is the croup. And it does get pretty bad after a while. Now, what is the other name for a common cold? It's called coryza. We could say it's an upper respiratory infection, but there is a name. It is called coryza. Now, it is not an allergy because there's no fever. There's not that sneezy, itchy, watery eyes that you see with allergies, right? Now, surfactant is something that is formed in a baby during pregnancy about the 24th week. Actually, it's the 34th week is when it starts putting surfactant in there. Now, we know the lungs are breathing by 24 weeks, yes, and they're trying to get there, but they'll collapse if there's this surfactant. It's a material that holds the alveoli open, okay? It's not really given till about 34 weeks, and the baby's lungs can now hold open and breathe back and forth without collapsing in between. If you ever work in OB, like, okay, the baby's 34 weeks, they've got surfactant, they're going to breathe okay. It's one of the things you'll remember. And that collapsing of those alveoli is called atelectasis. Could be due to many different reasons. Many times it's mucus, no coughing, deep breathing after surgery, right? That has atelectasis of the lungs. Now, some of the common illnesses in children is RSV. It's a respiratory syncytial virus, and it is more dangerous in your younger children. Me and you, that's a common cold. But on an infant, it's a lot of mucus, little fever, and it's hard to suck, swallow, and breathe. And it is the single most important pathogen, and it causes viral pneumonia. Remember, RSV is respiratory syncytial virus. It causes a viral pneumonia. How do we treat it? Tylenol, Motrin, fluids, rest. There's no antibiotics for a virus. And then asthma. Asthma is one of those things that's chronic, and it's the principal cause for children to go to ERs, doctor's offices, hospitalization, and absenteeism. The kid can't breathe, they can't go to school. And if you can't breathe, it needs treatment. And we know we treat asthma with, the rescue first, the albuterol and steroids, and eventually those lungs will open up again. And this is expiratory wheezing. Respiratory continued, you've got cystic fibrosis. This is a congenital defect that you get from mom and dad, and it's all about mucus. So this thick mucus obstructs the lungs. So it's like these big, thick petri dishes in the lungs. So you're always getting infections. So you have to do amazing respiratory care and get that mucus going. Now, another thing is the small intestines has mucus in it, and the digestive enzymes don't work, and the pancreas is not, it's full of mucus and doesn't secrete their enzyme. So you're not going to absorb food. You are going to see this child, now I'm not telling you should, but if you had an infant you knew with cystic fibrosis, if you licked their skin, it would be extremely salty. Now, you could tell the parent to do that, but don't you be licking children, okay? But it's that severe, it's that salty in it. That's why they do, the sweat test, which is looking for salt. So that's losing electrolytes. Never, ever take the salt shaker away from a cystic fibrosis child. And the stools are nasty. They're bulky, frothy, and the stink is amazing, like terrible. And they are infertile. Women can have children, but it's highly high risk. But men, because their vas deferens has mucus in there, the sperm can't get to the woman. So that's what causes infertility. 2 years after a bilateral lung transplant, they can, 1 year after, they can get a woman pregnant. So there is a possibility for men, just to let you know. Laryngotracheal bronchitis, LTB. This is all upper airway. Again, this is croup, and this is stridor. This is inspiratory. This is a barking cough. You can hear it, and you will always, that's croup. You know what that child has. Stridor is that you're trying to get air in, and it's swollen. That epiglottis actually is part of the tracheobronchial tree in there, right? And it's covering it and swelling it, and air can't get in, and it creates this whistling type stuff. And then the bark, bark, bark. Now, if you leave this laryngotracheal bronchitis, or the other name is croup, you can have epiglottitis. Well, the epiglottis does what? It's that big flap of skin that covers the trachea when you swallow and eat to protect from aspirating into the lungs. Well, this swells up over the trachea and you can't get air in. It's that tissue right above the vocal cords, and it is caused by H. influenza, which is a virus. Okay. And this is a life-threatening emergency. If you have a trachea and something's covering it and you can't get air in, you're not breathing. These children will have a tracheostomy many times or be intubated if they can get a tube in there. Very serious, life-threatening. Now let's go into some hearts. Now, this is probably my specialty of all of the areas. I worked 10 years at Miami Children's Cardiac Intensive Care Unit when they opened up that unit, and it's near and dear to my heart. So if you have any questions, stop me and I will let you know. Now, most of the things that happen with hearts is because they are born with it, congenital. The heart is the first body system to function. So we can hear a heartbeat, what, at 6 weeks? It's really, really early if we can get a hold of it. So the heart, one of the first things that is working. Now, terms. Tachy is fast, Brady is slow, dys is something that's not right, like dyspnea, difficulty breathing, right? Dysphagia, difficulty swallowing. So that's the dys. Hypoplastic is something where it's small. It didn't form at the right size. For instance, there's something called a hypoplastic left heart. Left ventricle is born very small and it doesn't work and the muscle doesn't work. Shunt is when we have blood flowing from high flow to low flow. That's what the body does. If you have a big flow, it's looking for it to go somewhere. So it'll go low flow, usually from the left side to the right side, if there's openings there. A murmur. A murmur is when the leaflets on those valves don't close all the way and you could hear the sound. For instance, a nice big VSD makes a murmur, and it sounds like instead of it's a normal heart rate, right? And the normal sound, but a VSD is you can in fact, you put your hand and feel the vibration, it's that much. Cyanotic is when they start turning colors. You know, their lips aren't pink, their tongues aren't pink, their ears, their fingers, you can see they're turning dusky due to lack of oxygen. Acyanotic is when there is a normal type of heart condition. Now, VSDs, ASDs, they're still getting oxygen around the body. It's an acyanotic heart disease. But like I said, that hypoplastic heart, where you have a small ventricle and the blood can't go around, that is a cyanotic heart disease. Tetralogy of Fallot, those tet spell things, that is a cyanotic. Those saturations go low. And then stroke volume is just the amount of blood that the heart beats in one contraction, just one stroke volume. So atrial septal defect. Well, an ASD, other name, is there's a septum or a wall between the right atrium and the left atrium, and there's a hole. And what happens is blood goes, as I said, it's usually from the left side to the right. Just think about blood, a drop of blood. When it goes around the body, it's, goes out of the heart, goes around the body, and then it just gets back to the right side, right? Through the vena cava. So the pressure is very low. If you look at the left atrium, you have blood flowing in there from the pulmonary veins, from the lungs. So there's big flow. So we know you're going to have it going from the left side into the right side, and all it does, it goes back into the lungs again. How do we treat this? Well, there are surgical closures that we can do, but there's also a calf closure where they put things where they, it's called a helix device actually, and it's like two saucers, and they do it through the opening in the groin, through the tube up into the heart, and one side goes on the left side of the atrium and the other one goes on the right, and it doesn't allow blood to go in there. So just to let you know what it is. VSD, same thing. but it is a hole between the wall of the bottom of the heart or the ventricles. Again, this causes more blood to go from the left, of course, to the right, back into the lungs. We know either ASD, VSD is just more flow. And again, surgery or cath lab. Patent ductus arteriosus, another word for that is what we use for fetal circulation, right? It connects the pulmonary artery to the aorta, so to the lungs, to the body. So we know blood can flow there. Now, when we see a patent ductus arteriosus, we need to be monitoring their blood pressure. You're going to see the numbers really far apart or wide pulse pressure. And it's something because it's doing this overflow of oxygen going around. We need to close it. And actually, we can see that number of the blood pressure coming back to normal. And there was also like a washer machine murmur there. We can hear that go away. So indomethacin is actually an NSAID. We give it IV and it closes it. Now, coarctation of the aorta. What you need to know about this is a kink when it comes off the aorta comes off the left ventricle and goes to the body. There's a kink, a narrowing, a restrictive area. So blood can't go all the way to the bottom. You know, that left ventricle's pumping like an engine, right? And it's trying to get blood in there, but it's narrow. So what happens? Well, you have higher upper extremity blood pressures because it can't go down to the feet. And the lower extremities are going to be lower. You're also going to see decreased pulses, if sometimes no pulses there. And because the blood can't go down, it's got to go somewhere. It can't just keep ballooning up the aorta, right? So it goes to levels of least resistance. That little pumper chamber of the left ventricle now is going to push it back up into the left atrium and back into the lungs, and it causes congestive heart failure. How do you know you're in congestive heart failure? Well, you're going to see a weight gain, right? Because it's extra fluid. These children will be tachypnic and tachycardic. And what they do is they usually go in and balloon it, or they have to go in and do surgery. And these kids do very well. Tetralogy of Fallot is probably the most common of all tested defects that there are. And I've heard it, some students come back to me and say, you're right, it was on my NCLEX. So tetralogy is a cyanotic heart disease. And there are 4 things that go with it. But basically, it's the pulmonary artery all of a sudden closes up, like a piece of tissue goes over and it spasms closed. And blood can't go from that right atrium up into the lungs. You're not getting oxygenated. So what do we see? Well, I've had it happen once. Had a newborn. His name was Nathan. I'll never forget him. He, at 5 o'clock in the morning, I'm changing in a diaper and just washing his little mouth, making him cute. And all of a sudden, he had a TET spell. He went from O2 sats of 100 down to 10 within seconds. So what do? We put them in a knee chest. Now, an infant, who's intubated on a, little warmer, you're just going to knee chest them there. You could take an older one, have it on your chest, and have them facing out and pull the knees up. What does that do? Well, it takes the abdominal cavity and pushes it sort of up into the thoracic cavity, and it changes pressure. And it pops open the pulmonary artery and lets blood flow. Okay? There is usually, that VSD opening. As I said, pulmonary artery stenosis, there's something happening there. And that aorta, it's overriding, it's just pushed over a little bit. And then because at the times where blood can't go up, it's going somewhere and it stretches out that right ventricle. Okay? So those are things you see there. I've mentioned the hypoplastic left heart. This is the most severe of all diagnoses, and this is an underdeveloped left ventricle. That means there's no pumping in this heart going on. And this child is going to require 3 stages of surgery. So it is a lifelong illness. And many of these children down the line, many of these get transplanted because their heart is just, you could see the aortic valve and the aorta very tiny. You could see there's a lot of stuff going on there, and just trying to get blood flow is really hard. So tests that we need to know. Well, an aortography. Well, that's what we would do for coarctation of an aorta, right? We want to see if there's a kink. Let's put some opaque dye material in the aorta and squirt it and see if there is an opening or where is that kink before we do surgery. That will be done. An echocardiogram is when we suspect a cardiac problem, and it's an ultrasound, just like we use for babies, right? But we're looking only at a heart, and it will see, is the structure normal? And as I said before, congestive heart failure, what do you see? Well, if the heart is congested, it means the blood's going to the area of least resistance, the lungs, and it's filling up with fluid. And the heart's trying to get oxygen to the body, but the fluid is covering up all the space. So you're going to be seeing a really sudden weight gain. That's why in the hospital, we are weighing these children every day on the same scale, hopefully. And because it's trying to pump over all of this congestion, it's going to be tachycardia when they're sleeping and dyspnea when they're sleeping because the baby's trying so hard. This kid's not going to be able to eat. Now, if you ever have any heart damage, what do we give? We know rheumatic fever. We can have heart valve damage, right? So what are we going to give for that? It's penicillin. And it's going to be a long term and up to 5 years prophylactically, right? Strep throat can do a lot. Now, we mentioned the glomerulonephritis, we mentioned the rheumatic fever, but anything in the upper airway. So it can go into the ears, right? And it can go into the lungs, and it can go into the blood system up to the brain. So all of these things can happen from a strep throat. So what does that mean for you as future nurses? You're going to make sure that these parents know that this child needs to take every last dose of their antibiotic so they don't have problems. That's what happens a lot. And I've even seen where 2 kids were sick, but they didn't have money for both antibiotics, so they split them. And you can see how dangerous this can be. I'm telling you, that's a reality. Now, blood disorders, anemia. Most common childhood blood disorder is iron deficient anemia, right? It's all about nutrition. What is anemia? Well, anemia is that you don't have all the red blood cells that you need. What are you going to see if you don't have enough red blood cells? You're not going to have enough oxygen or iron. This kid's not going to have any energy and is going to tire out easily. Those are usually the things that bring them to the doctor. We know that the hemoglobin is the protein that carries the oxygen. And we know that it can happen where we lose blood, right? You have a gunshot wound and blood goes out, or any big cut where you lose blood. Well, that you're anemic. Or it could be that chronic state, like iron deficient anemia, and we'll go into some other things too. It's either inherited or acquired. And anemia is either they're not producing enough blood or it's destroying the blood or you're losing it. So, iron deficient anemia, most common, right? Well, too much of what do we need? Well, these children need iron. Usually, the first thing that we'll treat it with is diet. Let them get the diet they need. And then if this liver, green leafy vegetables are the big ones that we like to, promote. but there are other ways of giving iron and, have the parents work with the child to get what they need. And if not, they're going to need an iron supplement. Hereditary blood disorder where the blood doesn't clot. You get a scratch, you keep bleeding, it doesn't stop. That's hemophilia. And there's a couple different types of hemophilia. The hereditary blood disorder where they're not producing sufficient adult hemoglobin. And this is called thalassemia. There are a couple different types of them, but when we talk about it, we're usually talking about major or Cooley's um, anemia, whereas this blood, I call them the rectangular shaped blood, where they have really short life and they burst. Now, what is inside that red blood cell that I told you? Iron and oxygen. So they're going to be tired and fatigued. They're not making cells, so hemoglobin hematocrit are really, really low. And then all that iron is being exploded into the body. So we have a problem with too much iron in the body, and that needs to be removed. Now, the other disorder where there's a change of shape in the cell is sickle cell anemia. And sickle cell anemia is when they go into a sickle. So we have thalassemia that are rectangular, burst, and sickle cell anemia also have a shorter lifetime. But this is something, again, hereditary. That's two parents have the trait, and they could have 1 in 4 will have it. And what do we do? And what do we promote for sickle cell? Well, what happens in sickle cell is these little sickle-shaped cells get to a bifurcation in a vessel, a vein, and it gets stuck. And other ones can't go through, so these cells back up, back up, back up, back up. And it stretches and it swells and it hits the nerves, creating all of this pain. And it's debilitating. What do we need to do? Well, we need to get that blood back through that vessel, right? So we need to hydrate, 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 and we need to put heat on it to dilate it. Now, we also, with giving this IV fluid, oral and IV, we're going to be given something for pain until we get it, cleared out. It is extremely painful. Hyperlipidemia is just excessive fat and fat-like substances in the body. And yes, children can have it. So GI-GU, we usually think about GI-GU with a loss of fluids, vomiting, diarrhea, and we know when you lose fluids, you're losing, number one, fluids, but all the electrolytes, right? You're going to be losing alkaline through diarrhea. You're going to lose acid. You just did the one on pyloric stenosis, right? Acid comes out. So if acid comes out with vomiting, you're left with alkalosis, right? And if you have diarrhea, losing all of the alkaline, what are you left with? Acid. So you're metabolic acidosis. Those are the two common ones that you'll be asked with questions, okay? So I know that dehydration is dangerous in children, so we really need to get it replaced quick. Now, in pyloric stenosis, it's different than just a little vomiting. Pyloric stenosis, 3 weeks to 3 months, about that age, that 6, 7 weeks is that sweet spot where you see a lot of them. And they'll come in with these new babies, and the mothers will say, my baby's vomiting a lot. My first question, is it a little bit or is it across the room? And watch out, it's going to hit the wall. And I'm serious, it can go 10 feet across the room. It is quite projectile. If it's projectile vomiting, we know most likely it's pyloric stenosis, and we'll feel that little olive or marble right underneath the xiphoid process. What we should do is preoperatively get them to the ultrasound and get an IV in them. And if there's any problems with the acid that's been coming out, we need to help correct that. Meckel's diverticulum is just a little bulge in the intestines. It's remnant ducts and stuff that were left. But the problem about these little tab things that are left there, they've got big blood vessels in them. So usually what happens is they rip. So if it rips, the blood starts dripping in the intestines, right? You'll see a painless rectal bleeding and usually minimal, if any, pain. So they'll do all their tests, whatever, and it's usually surgery of the small intestines. They take it out and they're fine. Appendicitis, McBurney point, right? Right lower quadrant, tenderness, rebound. Most common. Now, our concern in appendicitis is if that appendix ruptures. If it ruptures, all of the material inside that appendix, it's that ending of the small intestines and large intestines, and the appendix is there, and it spews into the peritoneal cavity and causes really bad peritonitis. These children will be on IV antibiotics and NPO for several days. Hirschsprung'S disease. Hirschsprung is where the lower part of the intestines, it tends to bulge and get big because there's no nerves in there. This little piece of intestines. So it gets big. There's no peristalsis. There's usually no stool at birth. And it's usually what they'll say, oh, this kid isn't stool. Let's look why. Well, Hirschsprung is one of the things that we look for. So once we determine that there is no nerves in that intestine area, they go and they take it out and they put on a colostomy. And then usually before 1 year, they'll reconnect it. So Hirschsprung does lead to a colostomy. Celiac disease, autoimmune, and it's all about gluten. Wheat, rye, barley, oats. They can't have any. And if they do, they're in severe pain. So they need to avoid gluten. So they need good protein, veggies, fruits, milks, dairies, all of those they can have, but no bread type stuff, no breading on chicken nuggets. Now, they do have things like rice flour now, and that actually can work. Kids are lucky today because there's a lot more understanding, and even the bakeries have gluten-free cupcakes and whatnot for kids. So that's awesome, to tell you the truth. 20, 30 years ago, never happened. So we've come a long way so far. So when we talk about children taking medications and just eating them because they taste good, acetaminophen is actually one of them. And we know that acetaminophen, Tylenol, is the very dangerous. It can really affect the liver. And this child is going to be sick. This kid will be admitted into the intensive care unit and monitored very closely. So acetaminophen, very common, and it does kill the liver. Acute glomerulonephritis. This is one of those things that react to the strep. Now, what do we see with acute glomerulonephritis? Well, you're going to see swelling. So big eyeballs, elevated blood pressure, no urine, oliguric, and maybe some like red, bloody looking urine. And how do we treat a strep infection? This child's going to get the antibiotics, right? Chronic constipation, kids, many of them are constipated. I tell my class, constipation is one thing a child can control. And many times there's psychosocial issues going on in the house and they hold their stool to get attention. But how do we, if just a normal child with constipation? Well, always increase fluids, increase fiber, and it's raw fruits and vegetables, not cooked. That takes away the fiber, so raw vegetables and fruit. Dysphagia, I mentioned it earlier, it's a dys, and that is the difficulty in swallowing. That right lower quadrant, we know McBurney's point, I mentioned it, is appendicitis. Now, GU, most common thing that happens to little girls is urinary tract infections. They wear those cute little tights. It makes it all hot there. They don't wipe front to back. They don't drink enough fluids. And it happens that, and they hold their urine. So little girls what we need to do, though, number one, is to increase the fluids on these children so they urinate more, and just wearing cotton underwear and not tights that keep it all hot and moist in there. In boys, there's a couple things you're going to see. Hypospadias. The other thing is epispadias. I don't have it there. But all it means is instead of the urethra on the end of a penis, hypospadias, there's nothing on the end. It comes out somewhere on the bottom, anywhere on the bottom. Yep. And they do surgery on this. They use the foreskin, so they can't be circumcised, and they will patch it up, and they do it before they're potty trained. And epispadias is on the top somewhere. So that was a different one. Cryptorchidism. Ever have a baby, a male, a little boy, bring him to the pediatrician? One of the first things they do is they feel their testicles, right? They want to make sure that the testicles came down. If they haven't, they may need to do surgery on them because they don't like the warm environment inside. Some skin things in Pentago. My grandson had a really bad case of this up the back of his leg, and it was oozy, juicy, painful, and it's a bacteria. Ringworm is fungal infection, so it needs a fungal cream. Pediculosis, lice. They need the shampoo for their hair and a fine tooth comb to get it out, and then you have to wash everything in the world. My daughter had hair down to her butt, and her ponytail was like 8 inches wide, and I had to put that comb through her hair, and she had it 3 times in kindergarten. Eczema. That's when your skin is really itchy, oozy, and it's just really hypersensitive. And there's a bunch of creams and, to have their nails short. Those fungal infections, we said ringworm, but it could be that capitis on their head. It could be on their feet. So fungals can be athlete's foot, any of those. Pediculosis is another lice. I got that. Scabies is little tiny little animals, and they look like little ants, and they get underneath the skin. Many times you go to a hotel, and that's where you get them from on vacation. And burns. Always know that you should know the rule of 9. Always know that with burns that you do wound care and you hydrate, and burns can be due to anything. So let's look at metabolic, type 1, type 2. Well, type 1 diabetes is what you see with kids. Some adolescents are type 2 because they're overweight, but in general, children are type 1. And once you're type 1, you're always type 1 because your pancreas isn't going to start to work. The triad of symptoms that you see are 3 Ps. They are hungry, they urinate, and they're thirsty. And the reason is why they're hungry is their sugar's not being digested. It's just sitting in the body. So they keep eating to try to get food. So that's what they see. And because they're not getting food, even though they're eating, they have a lot of weight loss. These children I've seen, 2 and 3-year-olds, all of a sudden in 2 weeks have lost 5-10 pounds. Little tiny little 50, 40-pound-year-old kids. And that's what brings them in. And then you say, yeah, polyphagia, polyuria, polydipsia. Those are the triad that you see. And then sometimes you might see them urinating at night in bed when they're already potty trained. So hypoglycemia, blood sugar goes too low. You see this a lot in children. Because remember, children are very hard to control. So you'll see them, they'll be hungry, weak, irritable, they'll be confused, they'll be pale, they'll sweat, and they, weak. They can't move their body the way that they should. So what do you need to do in hypoglycemia? Well, you need to get that blood sugar up quick. They're saying 8 ounces of skim milk is fine, and that will do it. Or 4 cubes of sugar. So enough to get that blood sugar up. Children like this always need to be carrying something with them. Cushing syndrome. Cushing syndrome is when the too many steroids in the body. Most of the time, this is due that you take steroids from conditions. Cortisol, steroids, it's the same thing. The adrenal gland produces cortisol. We take steroids, which is that synthetic cortisol. If it's been given too much, too long, they end up with these big round moon faces. Their cheeks they're called ruddy. Ruddy means red. You can see them nice and red. And you'll see these skinny arms and legs, but you'll see them with fat deposits around their abdomen and their trunk. Diabetes insipidus has nothing to do with blood sugars. Okay? Nothing. It has to do with the pituitary gland, which secretes something that helps with urinating so that you urinate enough, keeps the kidneys urinating. So now you gotta be very paid attention. Diabetes insipidus is 2 Ps, very similar to diabetes mellitus, but you're not hungry because this is only fluid that we're worried about. Polyuria, urinating too much. Polydipsia, drinking too much. Those are the things you see. Now, because you're urinating a lot, again, you worry about electrolyte imbalances on these, okay? And because you're losing so much, you really got to monitor vital signs. So vaccines are given, and this is called acquired immunity. The other way to get it is if you have the disease, but vaccines give the acquired. I don't know how many times I have to say dysphagia today, right? Difficulty swallowing. And then how do you treat hypertension in children? Well, we don't like to put them right on meds at all. So we'll put them on low fat. These kids are over 2, the central nervous system's grown, we're okay. Low fat, fruits, vegetables, fish, poultry, and low sodium products, and a little bit of activity. And that usually will help it. Now, we talked about erythrocytes, which are red blood cells, right? Well, sometimes, the kidneys produce something called erythropoietin, and that regulates red blood cell production. But we can give an injection of it too when you have a child that has a condition where they're losing blood. So erythropoietin is for red blood cells. So again, when you're looking at those dosage calculations, you're going to know that you have to take pounds, make it to kilograms. You're going to have how much is the dose, and then how much are we going to be given if they give you a vial of something to use. Remember to be very careful about, is it per day or per dose? Because it might say 2 milligrams per kilogram per day, and they'll say it's in 2 doses a day, and then they'll ask how much you give per dose of the medicine. So be careful with that. And then I have, again, given you a very short calculation review here. It's less than 20 minutes. If you're confused, please look at it. It will help you. Any questions, anybody? A lot of intense stuff. I'll be sending this out pretty soon, and I'll be sending it to your professors. Those who wanted to do that dosage calc, we can do that. I will be sending it to you. Make sure you send me that message in Canvas for tomorrow, okay? So that we can get that set up, because a lot of you are Monday, Tuesday classes. Okay? Thank you, everybody. Have a great day.